welcome and updates. So welcome. I'm excited to see everybody. So the first presentation will be on billing and coding. We will have Angela Berry from GoTo. Then we'll have a Q&A session. And then imagine that a lot of people would have questions, but I also have questions in case I'll kind of put in if anyone is wondering. And then I'll also be monitoring the chat. And, if we do not get to your question, I'll be taking note of those and making sure that we get those answered for you. After the Q&A, we're going to have a presentation from ECU with Jennifer Lewis. Then we're going to have an ECU Q&A, and then we're going to do wrap up and announcements. So I am excited to get started and jump right into it. Angela, if you are ready, I will just do a brief introduction on our speakers. All right. So Angela Berry has been with GoTo for lung cancer for 10 years, currently serving as the Director of Quality Screening and Program Initiatives, working with the Centers of Excellence programs to advance best practices implementation and drive patient-centered care delivery across the lung cancer continuum, from screening to early detection through diagnosis, treatment, and survivorship. The Kentucky Center for Smoke-Free Policy, the UK College of Nursing, recognized her in 2020 with the Timothy W. Mullett, MD, Lung Cancer Prevention Award. She previously managed the Kentucky Department for Public Health Tobacco Prevention and Cessation Program and has an MA from the University of Virginia. So Angela, I am so excited to have you here. I will go ahead for your presentation.
Right. So basically, this whole question of, questions that arise around issues of lung cancer screening coverage and how to bill appropriately and so forth, it can feel like, if anyone is a fan of Lord of the Rings, it can feel very much like there's someone standing in your way saying, you shall not pass. It can be really frustrating and complicated. So I just want to validate those feelings as we get going with this. If you'll move on to the next slide. I'll be going through these pretty quick because I have a number of slides and I'm sure y'all have a lot of questions. So I wanted to start with just a little bit of a refresh on the paths that lead to coverage. I assume that everyone here probably is very, very familiar, but just to make sure, there are several paths that lead to coverage and some that are dead end. So with commercial insurance, you have those that comply with the Affordable Care Act. And then you have grandfathered plans, which I'm going to touch on. And grandfathered plans are a problem. Then within Medicare, you have traditional fee-for-service Medicare, and then you have Medicare Advantage. And Medicare Advantage should not be a problem, but sometimes it is. And then you have Medicaid, and there's a difference between the original Medicaid plans and the Medicaid expansion plans. And then there are still some short-term plans and association plans and so forth. Those really became popular during the first Trump administration. There were a lot of the regulations around what was allowable that were relaxed. And so these plans took off, and a lot of insurance brokers would market them as less costly, but still comprehensive coverage. And then the people who would buy them would later find out, no, these don't provide with the full complement of coverage that an ACA plan provides, including, in many cases, preventive service coverage. And so people were stuck with bills sometimes. And the successor administration, the Biden administration, reimposed some of those regulatory constraints. And now I suspect we likely will wind up with a lot of loosening of that again, which can make insurance plans more affordable for some, but also reduce the coverage that's included, sometimes unexpectedly. Okay, on to the next slide for me. And I talk fast, especially when I have a lot to cover. So please raise your hand or interrupt me if I'm going too fast. So the two biggest umbrellas where there is supposed to be coverage for lung cancer screening are under the Affordable Care Act and then with Medicare. Next slide. So, of course, I think we all know the Affordable Care Act mandates preventive service coverage for this group of plans that are covered by the Affordable Care Act. And this is for any service that has a U.S. Preventive Service Task Force A or B recommendation. Of course, lung cancer screening has a B recommendation. Now, there's not time to go into great detail about this, but there are, of course, threats to the U.S. Preventive Service coverage mandate currently. It is still in place with the exception of a couple of plaintiffs in a court case that began in Texas. The complainants were known under the label of Braidwood, which is the main company that challenged it legally. Went through the district court, Court of Appeals. Court of Appeals said the U.S. Preventive Service Task Force is unconstitutional in terms of it is not a body that has the power to make any sort of enforceable law. That's what its recommendations are under the Affordable Care Act, but the members are not appointed by the president and confirmed by the Senate, and therefore their decisions don't have the force of law. It is unconstitutional for it to do so. But the court said, we agree it's unconstitutional. However, we're only applying the relief to the plaintiffs. This is now going before the U.S. Supreme Court. The oral arguments are April 21st. So I think everybody is holding their breath because we don't really know what will happen in terms of this preventive service coverage as a result of this court case. Right now, the enforcement is still in place for all but those few plaintiffs that brought that court case. Okay, on to the next slide for me. So commercial payers are mandated, as I said, to cover A and B recommendations without copay or cost sharing. As long as the plan holder's in network, if they're out of network, they may face cost sharing. Okay, on to the next slide. There's some exceptions though, and those are grandfathered plans. Today, there are not nearly as many. Over the years, a lot of plans that were grandfathered have made enough substantive changes in their plan that they have fallen out of that grandfather status and are now required to meet the ACA. But there are still some out there, and I do periodically hear of union health plans, for instance, in particular, that are outside the ACA's coverage requirement. Some plans still are voluntarily covering, even though they don't have to. But this can still be a problem. Next slide. If a plan is grandfathered, it is supposed to be clearly explained to the plan holder in their summary benefits and coverage. And the U.S. Department of Labor that regulates this under ERISA has template language that aren't required to use this language, but this is the language they suggest. And they specify in there that you may not be covered for preventive services, for instance. Okay, on to the next slide. Medicaid expansion has to cover all USPSTF grade A and B preventive services without copay or cost sharing. Even though CMS, it's Center for Medicare and Medicaid Services, Medicaid's different from Medicare, regulated differently. It's regulated by the states. It falls under the ACA, and the Medicaid expansion does. Okay, go ahead and hit enter because there's a couple of bullet points that come up. But states have an incentive individuals that meets the USPSTF A and B with no copay or cost sharing, they receive this FMAP percentage of an incentive. And okay, next slide. That just shows you the impact. Increase in uptake. Of course, BCBS, Healthy Blue, has a Medicaid one. And then you can see the age group here, the relevant age group is only a small sector of the Medicaid expansion enrollment. Okay, on to the next slide. Oh, and at the bottom of that slide, sorry, I did include a screen capture that shows. So yeah, on to the next slide. So of course, Medicare issued their original coverage determination back in 2015, and then they revised it in 2022 to meet the new USPSTF recommendation with the exception of the upper age limit. And again, as long as a Medicare beneficiary, their specific requirement for age and PAC year history and so forth, then they should not have any copay or cost sharing, whether they are covered under traditional Medicare fee-for-service or if they have a Medicare Advantage plan. On to the next slide. I say that, but CMS gives Medicare Advantage plans a lot of latitude. They have to cover the same thing, but the rules about how they do it can be different. So, theoretically, or actually legally, a Medicare Advantage plan holder, just like as if they had fee-for-service Medicare, if it's in a national coverage determination, they're supposed to have the same benefit. So they should not have to pay a copay or cost sharing. But with Medicare Advantage, they have a network, and if they go outside that network, then they may have to pay. As of a couple of years ago, when I first started diving into this, a third of Medicare beneficiaries are covered by Medicare Advantage plans. That is rapidly growing. Now I think it's closer to half. It's substantially more than that are covered by Medicare Advantage now. Okay, if you'll on to the next slide. Now, there have been a lot of problems with Medicare Advantage, dating all the way back to 2018. There was an Inspector General's office investigation into Medicare Advantage. There was a follow-up in either 2022 or 2023, and my apologies, I did not have time to update this slide, but they found the exact same thing, that Medicare Advantage plans were inappropriately denying or delaying care for things that should be covered if the person were enrolled in Medicare fee-for-service, services that these Medicare beneficiaries are entitled to. But when people appealed it, the appeals were very successful. Most people didn't bother to appeal. They didn't necessarily know about the option. But if they did take the time and effort to appeal, which for our population of lung cancer screening that are oftentimes low socioeconomic status, very disadvantaged, this can be a heavy burden for them. But if they do have an advocate that works with them, especially someone from a screening program, for instance, then generally these appeals are successful. That follow-up Office of Inspector General investigation that was, like I said, 2022, 2023, found that advanced imaging is among the most frequently inappropriately denied or delayed coverage for Medicare Advantage holders. Okay, and that can lead some providers to not refer patients because they've come upon a pattern of denial, and when they don't refer, then those patients don't get screened, and the opportunity for early detection is lost. This slide is just to show you set the context for some of the importance of this, because we have done surveys and we are fielding a survey right now with our centers of excellence. This one dates back to 2019, so before the pandemic. We asked our screening programs across our network about the barriers that they were perceiving that their patients were encountering. This was a free response. We did not give them responses to select. They just gave us their free response, and then we coded those responses. And of course, as expected, the biggest barrier to uptake was lack of awareness and referral, but insurance and financial were the next ranked things that were mentioned. But then when it came time for the patient to come back after that first baseline screening, when they were coming back for their next annual, insurance, the top barrier that screening programs perceived that was keeping their patients from coming back. So this does have a real world impact. So the coding complexity, I think this is the main thing, questions that y'all had. And of course, I know we're short on time, but I will gladly follow up one-on-one, via email, phone, however I can be of assistance to you all. There are so many complexities around specific coding. And of course, when it's no longer new, but the 71271 code was created to replace that old G0297 code, that temporary code. It created some confusion because it's placed right there within the diagnostic chest CT codes. And so a lot of payers were thinking, this isn't a screening code. And they were billing it as if it was diagnostic because of that. It took a while for that to catch up. That may still happen sometimes. The main thing that we found, though, are the differing requirements around the ICD-10 codes that establish medical necessity for this screening preventive service. And when you don't use the right code, it gets processed as diagnostic, and that patient gets a bill that they shouldn't have. And a lot of programs feel like they've got a blindfold on and they're spun around and then expected to pin that tail on the donkey to find the right code on behalf of their patients. And it's really unfortunate. Next slide, please. So this is the list of codes that it's a CMS allowable. These are the only ones that CMS allows, okay? So personal history of nicotine for those who previously smoked, and then the list of cigarette-specific nicotine dependence codes. You cannot use the ones that are not specific to cigarettes. These are the only ICD-10 codes that CMS will accept. If you use an additional code, it can very well be denied. The payment can be denied. But over on the right, you'll see that some commercial insurers require a different code, Z12.2, for instance, encounter for screening for malignant neoplasm. And they may want that in addition to one of the CMS codes or instead of. It varies from payer to payer. And so what we have recommended is that screening programs sometimes adopt payer-specific billing strategies. So maybe they default to the CMS codes, and then if they get a denial, then they try the Z12.2 and see what formula works on behalf of that patient. But they have to hear from the patient and know that they got a bill before they can try and correct that with their billing department. On to the next slide. So go ahead and hit enter because there's a balloon that comes up. CMS is aware of this, and they sent a letter back in late 2023 to all the Medicare managed the MCOs and the Medicare Advantage plans that urged them to not reject covered preventive services simply because of ICD-10 codes, unrelated diagnostic codes, or because they didn't use a specific preventive service procedure code. If it's supposed to be screening, supposed to be preventive, it needs to be processed that way under federal law. So this is a lot of words. How do they enforce it? There's never been any clarity on how they enforce it, but they did at least articulate that this is the federal law and you're expected to adhere to it. Okay, next slide. The biggest thing we hear about now is site of service denial, and I suspect this is a big problem. Blue Cross Blue Shield, North Carolina, has 80% of the plans in the state, I understand. Carolyn is the benefits manager for Blue Cross Blue Shield of North Carolina, and they do specifically have a site of care policy when it comes to lung cancer screening. At the bottom of the screen, 71271, you'll see it included in the list of codes that this site of service policy applies to. They've finessed the language a bit. United Healthcare, Anthem, Aetna have their own policies that are very, very clear that we will not cover in a hospital outpatient imaging center unless there's these specific reasons that it meets medical necessity. Their language is a little bit softer, but they say that this is designed to define the clinical scenario in which it's medically appropriate for this to take place in a hospital outpatient setting versus a non-hospital setting. And their default is it is to be done in a non-hospital setting unless there's a specific reason that it's medically necessary. And they have a really short list of what requires medical necessity. One of them is the need to compare with prior studies. So if you have a screening patient that has nodules that are being followed, then you need to be able to compare with the prior study. That meets the medical necessity. But somebody coming in for a baseline, or someone who has no nodules, this could really impact their ability to be seen in a hospital outpatient imaging setting. On to the next slide. So who can help? I've tried to compile some North Carolina specific information here. For Medicare Part B fee for service, your Medicare administrative contractor, that there's a little QR code there that takes you straight to Palmetto GBA, their contact form, okay? Or you can call them. Medicare Advantage has a specific appeals process that's outlined on their website. And I've included that website and where you can submit questions. Commercial plans, my best advice is to reach out to your Department of Insurance Consumer Services Division. I've included a link to their process for assistance or filing a complaint online and their telephone number. And then there's another organization that we've worked with over the years at various points called the AIMED Alliance. They are specifically focused on protecting the rights of healthcare consumers and providers around payer barriers and coverage barriers. They have a website called Know Your Rights. I was going to link to it, but their security certificate is apparently lapsed, and so it was giving me a warning. I know their site is good, but right now there's that warning. So it's linked from the AIMED Alliance website. I encourage you to check it out later once they've had a chance to remedy their security certificate. They're an excellent group to partner with. And then the resources that we have, a one-pager that we have crafted. It's brand new. It is not yet up on our website. We'll be getting it up there soon, but Hannah has a copy to share with you all if she hasn't already. And then the ACR has their own one-pager screening, economics, and billing resource, and I've included a QR code directly to it, so you can download it as well. And then my contact information is next, I think. and I've talked fast. Apologies, especially when I'm frazzled after the snafu trying to get into the meeting. When I'm pulled in a bunch of different directions, I'll talk more quickly. So I hope that I have helped and not confused more. But if there are questions, I welcome them.
Right. So into our next speaker. Our next speaker will be Jennifer Lewis. She serves as the outreach coordinator for the ECU Health Medical Center Cancer Care and has worked for ECU Health for 32 years, 27 of them as a nurse. She joined ECU Health Cancer Care in September of 2021 as the outreach coordinator for the ECU Health Center. Jennifer leads the monthly free LDCT lung cancer screening program for the underserved, as well as the monthly free breast cancer clinic for women over 40 without health insurance. Jennifer believes in the value of cultivating strong partnerships with community organizations in order to promote awareness regarding prevention and early detection of cancer. Jennifer received her associate degree in nursing from Beaufort County Community College and her Bachelor of Science in Nursing from UNC Wilmington. So thank you for joining us, Jennifer. And if you're ready, I am good to start your presentation.
That sounds great. Thank you, Hannah. Right. Hey, everybody. Very happy to be here to share for a few moments about our free low-dose CT lung cancer screening program that we started back in 2021. If any of you were at the stakeholder meeting in Chapel Hill at the beginning of the year, I presented there, and so much of the same information, but really did just want to highlight this for this Navigator network. So next slide, Hannah. So a little bit of background of how we are able to provide a clinic for the uninsured communities of Eastern North Carolina. Here at ECU Health, we do have a foundation like many hospitals do, and they have a particular grant program called the Community Benefit Grant. And what that does is it awards monies every year to nonprofits in our area that are doing the work of the priorities that are set forth through our community health needs assessment every 3 years. So right around the time that I started in this role as outreach coordinator in 2021, the young lady that was in this role before me had written a grant for the low-dose CT lung cancer screening program, partnering with the ECU Brody School of Medicine. Typically, ECU Health does not fund programs for ECU Health with this grant program, but what we were able to do is have the funds go through the Brody School of Medicine. Now we are a joint. Back then we were Vidant Health, and since then we have merged with ECU East Carolina University. So now we're joint. So I'm not sure if we'd be able to do that again, but I feel certain that we'd be able to sustain this program once it's over, once we've met our goal of screenings. So anyway, this grant is to, just like our mission states, to improve the health and well-being of Eastern North Carolina. And a little bit of background is we were awarded $44,000 to pay for 169 low-dose CT lung cancer screening. So that was in 2021. Those that wrote the grant negotiated with ECU Health CT's department and Eastern Radiology, which is a local radiology firm here, for to complete these scans for $250. $200 would be for the actual technical fee of doing the CT, and $50 would be for the read fee. The grant also included some transportation assistance, like a lot of us in North Carolina, we're very rural, and this grant would be for anyone in our 29 county service area. So we set aside for $75 $20 gas cards for those that are traveling an extended distance to get to the medical center. Of course, as you can imagine, this opportunity is for the low-dose CT scan and the reading. Our first clinic, yes, did start on December 2021. We had one patient. Next slide. This next slide really shows the footprint for ECU Health. The yellow is kind of our flagship. That's where I'm located, at the medical center. And then we have 8 regional hospitals that are dotted around. So this grant does does serve this whole area that you see on the map. If you are eligible for a lung cancer screening as set forth as Angela was just saying, if you meet the guidelines, 50 to 80, 20-pack year smoking history, current smoker, or quit within the past 15 years with no signs and symptoms of lung cancer. And our eligibility for the program is that you're uninsured, resident of Eastern North Carolina, and that you have completed a low-dose CT screening, that your provider has completed a low-dose CT screening form, and that you do meet the guidelines on the right bottom part of this page. Next slide. So this is an example of our referral form. This is a one page that was created. The left is the front, the back is the right. So this form is actually completed by the provider and emailed or faxed directly to me. We, of course, have centralized scheduling, but we do not go through them to do this program because we want to ensure that patients are scheduled on the correct day. We do our screening the fourth Wednesday of every month in the afternoon. CT is blocked time out for us to use. We want to make sure our patients don't receive bills, so they are entered separately to ensure that bills don't go to their homes. We never want to represent ourselves incorrectly and have a patient deal with the stress of getting a bill when they were told they weren't. So the left-hand side is what the provider, it's more for the provider to read. I don't take these forms out to the community, to community health events where we're promoting lung cancer awareness, because some of it can seem a little bit, some of the verbiage on it may just seem a little bit high level for our health literacy in our area. We do have promotional forms that we share, awareness forms that we share that are written in a more easy to understand way, but this is mainly for our providers to see. And then what will happen is when they see a patient, they feel like the patient is a candidate for our program, they can fill this form out and it is faxed to me. And if you look at the bottom of this form, and I know it's sort of difficult to see, I ensure that the form is completed properly and that the patient really does meet the guidelines and that they are uninsured. And then I will call the patient and actually schedule them for one of our upcoming monthly appointments. And once I schedule the patient, I complete the bottom portion, letting with the date and the time and where, which is going to be here at the medical center. And then I send this back to the referring provider so they know that I have scheduled their patient. Next slide. Once I've talked to the patient, of course, I confirm that, sometimes our patients, if the doctors maybe don't do the best job at explaining or the best job at the shared decision making, I have information that I do mail to them. This is a letter that they will get after I've scheduled their appointment, just sort of reiterating when and where, how to get there, our address, our medical center campus. It's nowhere near as big as some, especially in the Triangle, but it is pretty intimidating. It's the biggest one in Eastern North Carolina. So there's a map. I meet our patients in the lobby because, when you're coming from out in a rural part of the area, and then you come to this huge hospital, it can be a bit intimidating. So they get this letter in the mail a couple weeks before their appointment. Next slide. They also get this educational sheet that they can just sit down at their leisure and read. I do explain what a low-dose CT lung cancer screening is, but if you don't know, you don't know. I do tell patients that it's very quick, and here at our hospital, I don't know what the parking is like in your area, but I tell patients it's going to take them longer to walk in than it's going to take walk in from the parking lot than what it's going to take to actually get their lung cancer screening. So they get a copy of this to read after I have explained it to them on the phone. So in their letter, they get this. And next slide. And then when they come to see us on the day of their clinic, which I call them the day before and make sure they remember to come and see if they have any questions, I greet them in the lobby. I walk with them to the CT lab. They get their CT. They get a thank you card from me. Also, touches on our quick line and reminds them that this is something they'll need to do yearly. They will get a letter of their results the following week, and their provider will also get the results. I go over the signs and symptoms of lung cancer to look for. And then if this particular person has traveled a distance to get to their screening, this is when I would give them a gas card. Next slide. Some points of pride. So we started this in 2021. To date, we have completed 110 free low-dose CTs. Started out really strong. We did 45 in 22. We did 42 in 2023. 2024, we really dropped down a lot in our referrals. And so in 2025, at the beginning of the year, I reintroduced, my interns helped me reintroduce the program. We sent out lots of mail-ins to over 55 FQHCs, just really reintroducing. I know there's some turnover in a lot of the FQHCs. So far this year, we have done 7. We've only had 1 clinic this year. Our January clinic had to be canceled because we don't know how to drive when there's a little bit of snow and ice around here. So, and that was when we had our little snow time. So we rescheduled those patients for February. Some good things is some of our low-dose CT patients, the females, have come in, and I've been able to connect them with our free breast clinic that we also do monthly. And then you'll see pictured here, I get interns. I actually get public health interns from East Carolina University each spring, and they're very helpful with education. It's a great experience for them. Next slide. Keys to success is clinic promotion, big time. And here you'll see what our providers get when I reintroduce the program. A letter, of course, directly from me. And then I've sent them all several copies of our referral forms that they can also reproduce. Next slide. Some opportunities, this is the last slide, I believe, is we really want to increase our clinic referrals, continue to promote lung cancer screening among our providers and communities, especially with our at-risk populations, and always reducing the stigma that surrounds smoking. I do think that's a lot of reason patients don't reach out to their doctors about lung cancer screening. They have this feeling that they sort of did this to themselves, and we really want to reduce that stigma, because I know if you're like me, there are some folks in your family that smoke and you happen to love them very, very much, and that's not what defines them. So, and a new opportunity I'm super excited about is our Screening Saves Lives partnership. They have chosen us to pilot with the Lung Cancer Initiative, is piloting with their Screening Saves Lives partnership with us. So that is launching in the next couple weeks, next couple months, actually. So we're excited about that. Over on the right, you'll see some of our collateral. I think that's what the marketing department likes to call this, what we share out in the community about lung cancer screening. The form on the left here shows you just an example of what we would give to a patient to really get that conversation started between them and their provider. And then the right card on the right is just some of our lung cancer services that we have here at ECU Health. I think that's the last slide, right, Hannah? Yes, that's it. So thank you so much for allowing. And it's not a lot of frills, it's nothing fancy, but we're getting it done, and I'm really excited that I really think this is going to be a great year for our program. Thanks to the Lung Cancer Initiative.
Yes, thank you so much, Jennifer. And we're excited for our partnership and excited that we got to hear about all that you guys are doing over at ECU Health. So now I will open up the floor for questions. It looks like we're running good on time. So if you have any questions, just go ahead and unmute yourself. And then if not, I will ask some questions.
From the Health in Winston-Salem. And I have a question about, you have a plan to resource patients if there's a positive finding? I mean, what happens to the patient if there's something that needs a PET scan and would lead to a lung cancer diagnosis? What supports the patient through? Do you have anything that supports the patient through this, or referring them to? What happens to them?
So I believe I didn't hear the beginning, but I think I heard enough. So yes, our patients, if there are suspicious findings, we make sure because a lot of our FQHCs do have access to Epic and they do see the results. But if there are patients with suspicious findings, I will connect directly with their primary care. If there's someone that needs to come back for a repeat or a PET scan, we connect. We make sure that they do have that continuity of care. Yes, yes.
But what's the resource if they're uninsured?
So that's a great question. So we also have the uninsured arm of ECU Health is Access East, and they have programs. They have ACA signups. They have programs that help with specialists, and that social worker does attend our free mammogram clinic to speak with our patients about either getting signed up for insurance or specialty care. So those patients, although Access East, their social workers don't come to our lung cancer screenings, I do send their information so their community outreach workers can follow up with our patients. But yes, that's a great question. We don't have another program here at ECU Health. This is just a screening program. So we don't have, with our breast program, we would refer them to the VSAT program. But yes, you're right. We do our best to get them connected to promote that continuity of care. But right now, that's the best that we do. Thank you for that question, though.
And Darcy had a question. Can patients receive? You see it, Jennifer?
Yeah, I just saw it. I believe she asked if patients can get a free low dose CT at any of our hospitals. Is that what I saw? So right now, so we have 8 regional hospitals, and ECU Health Beaufort, who is east of us, they have done a free clinic. And this is actually 4 of our hospitals are part of a network accreditation, our cancer accreditation that many of you probably know about, those of you that are cancer centers. So we have chosen lung to be our site for our prevention and screening standards, 8.2 and 8.3. So what will happen is this year, all 4 of those sites, including us, will have to hold free lung cancer screening clinics this year. It is my goal that all the hospitals are able to do this. Right now, the grant is just for patients to come to the medical center, simply because it would just be really difficult to manage billing for this grant if patients were going all throughout the system to get there and on different days to get their low-dose CTs. So we're really hopeful. A lot of our hospitals do have foundations, thankfully, and we do have great donors. So hopefully this will be a program that can be replicated throughout the regional hospitals. We've done a really good job of doing that for our breast patients. As far as having uninsured screenings, I know that the Wise Woman program does those at the health departments, but we're able to enhance their efforts and do some here at our hospital as well.
Thank you, Jennifer. This is Darcy. The only reason I was asking, you and I need to connect offline because we've had some people reach out to us with our mobile lung screening program that serves the underserved about going into Eastern North Carolina. And so I want to make sure I'm funneling them to you.
Right.
So let's set up some time. I apologize. I'm trying to cram too much into this tiny little chat. So
that's okay. That's fine. I'd love to chat with you more. Yes. Yes, this is for everyone, and I know it's a distance to travel, and I am hopeful that we'll be able to move this actually to the regional sites in the near future.
Is there anything in the chat that anyone's asking that I might be missing, or?
So I think Hillary had a question too. But Jennifer, does the grant cover only new screenings or the annual screenings as well?
So I am, I'm doing, if I am doing annual screenings with this. So if someone was screened last year, I'm doing them until they run out. I'm doing them until I have met that 169, and then I feel certain that we'll be able to continue to do them with our foundation. But yes, if you were screened with me last year and it's time for your annual screening this year, as long as this program is working, I'm doing them with a referral.
Jennifer, do you require another order for their annual? Or do you guys just cover that order? Because that's something we always ran into with the underserved, them not getting another order placed for the next year.
That's another great question, because we have had patients that they'll get their letter that they need to have another one, right? They'll get it, and they'll actually get it from the thoracic clinic. The coordinator with the thoracic clinic, Courtney Perisher, she will actually send those letters out for patients to get their annual lead OCT, and she will try to pump those over to me. She does a great job of pumping those over. So occasionally I'll get a patient and I know they need to have one done. I have filled out the referral form and forward it to the primary. I have faxed it over to the primary care provider to complete and send back to me. And I feel like that's going to be a lot of what happens. Me kind of navigating that for the patient, making sure that their doctors, kind of being that go between. Hey, your patient is they're due. Can you, let's fill this out and get it back to me, and I can get them scheduled.
Yeah, we just eliminated that completely and just started writing our own orders with our own provider, just because it was such a barrier for follow-up. And there's no more reason for us to give these folks not to get their follow-up scan. And so we just kind of we did that just internally. And then, of course, we verified that they still have a primary care provider, and then make sure the primary care receives those results on the back end. But that was a huge part when we started, that we were getting only about 10% of orders written for follow-up scans. And so it was just such a big barrier.
That's great to know. We have, so the doctor that co-authored this grant, he's a radiation oncologist. He is on for attending, but then we have the ordering, the referral doctor, and he has shared, if you have a patient, if you ever get a patient that doesn't have a primary care provider, or, you give me a call and I'll help you get them scheduled. I've not had to do that yet, but I do feel like I would like to do what you've done, Darcy, as far as having that standing order, because I really feel like I would be done. It would provide better care, more continuity, because we're having patients that need to come back and their doctors aren't ordering, or they're not going back to get them ordered. So that's the next phase to my reintroduction to this program, is to really start going through and looking. Some folks have been coming back, but there's several that I know need to come back.
Yeah, let's catch up.
Whether or not they've gotten insurance between, a lot of folks have signed up for ACA, and I really thought that the ACA was going to make our free breast clinic just kind of disappear, but it is not. We have now our free breast clinic is probably 90% Hispanic. So, but yes, so it may be that. But yes, let's talk, Darcy.
Perfect.
So with that, thank you, Jennifer, and thank you for everyone asking questions. Again, if you put a message in the chat or message me directly, I am going to go back and look and make sure all of your questions get answered by our speakers. But with that, I'm going to go ahead and wrap up. Let me click here if this will let me click. Yep. Okay. So all of the information will be sent via email after the meeting. I will try to get that out tomorrow morning. So the slides, any documentation that the speakers wanted me to share with you. But thank you to both of our speakers for taking the time out of your day to join us today. I apologize for the mild technical difficulty. So with that, I now know that if you did not register through the website and then you go to the Zoom link itself, it will say invalid. So make sure, and all of that, all the registration stuff is on the website. It's just that the Zoom link was in the calendar invite, not the registration link. So now we know. So make sure that everyone is able to register. But thank you all for joining us today. And let me know if you have any questions or any follow-ups. But I will be sending a follow-up email at the end. But thank you guys so much.